rhinoplasty. الدكتور ياسر أحمد العطية حاصل على شهادة برعاية جراحة تجميلية، عضو الكلية الملكية للجراحين في إنجلترا، عضو جمعية جراحة التجميل العلمية. ويتفضل مشكورا لإلقاء محاضرته.
السلام عليكم. Zanno to complete the circuit what we have talking about eclectic and palette is a big subject. The team, as they said, we have to deal with it as a team. It started not just after the birth of the child. It should be started from the antenatal care to prepare the parents to care about their child. I'll talk about mature cleft rhinoplasty. As we know, we have primary rhinoplasty, which we can do it at the time of primary lip repair, or intermediate rhinoplasty from the time of after the time of primary lip repair to the time of maturity. Nowadays, the use of intermediate rhinoplasty is let's say less common to be used. Regarding mature cleft rhinoplasty, historical problem seeking definitive solution. Over a century of work, many techniques have been used to achieve most acceptable results, but unfortunately, few consistent results and few perfect results. Many deformities remain after all efforts to get the best results. As we know, primary rhinoplasty are dealing with complex deformity, but with consistent presentation and handful technique can be used. And when we operate on a virgin tissue, unlike when we operate on a scarred tissue with inability to move the tissue as we want. Patients are so unaware about the results. Many surgeons I work with them do lift the repair and they put in mind he may need surgery later on. In opposite to mature cleft rhinoplasty, the complex deformity highly variable and the technique to be used limited to each case. And the tissue very scary, patient very aware, and there is no other chance to interfere. The patient has been waiting this moment since childhood. As we know, he has been told when we get mature, he will get rid from this deformity. I want to talk about some difference between cosmetic and mature cleft rhinoplasty. Although cosmetic rhinoplasty, even if it can with major complications, much easier to deal with it. In many primary cases, asymmetry but mild. Mild airway obstruction, established technique can be used for each case and can get home runs. Indifferent to all cases of cleft rhinoplasty, all of it are secondary, asymmetrically severe, major airway obstruction. You have to think out of the box to bring the best solution for this case. As a philosophy, when we deal with lip revision, simply you can excise the scar completely and rearrange the tissue. While in cleft rhinoplasty, you don't have this opportunity. You have to do what we call it cumulative nasal reconstruction, not to recruit. All surgery creates more scar, skin cartilage, mucosa, all are deformed. More scar limit nasal manipulation. Even if you bring hard tissue, such as costal cartilage, still you have to deal with a hard tissue. You don't have the old ability to get what you want. And unfortunately, even if you have put in your mind a plan for the surgery, during the surgery you will be surprised on some difficulty to get the best result you want. Some challenges regarding cleft rhinoplasty, the scary, overrated nose. Look at this nose. For that reason, we are talking about the care from the first time of surgery. This patient has underwent rim incisions to go to get primary rhinoplasty. At maturity, the scar has been made the nose like this. So even if I plan to do primary rhinoplasty at the time of primary lip repair, we have to put in our mind minimally interfere with the cartilage and tissue, because surgery is a scar. Whatever you intervene will affect the growth, which is almost hypoplastic. Another problem, flattened nasal tip mass. This patient with bilateral cleft lip, even if I am planning to recruit the cartilage, the columella, even and the lower lateral cartilage, I will be unable to bring the tissue around them. Right nasal base is carrying thick, dense skin. In addition, not each case are the same. We are dealing with skin and envelope and support. In order to get the best results, I have to bring the good support. Most of the patients with cleft lip and cleft palate especially have maxillary hypoplasia. Large number of them may get treated before rhinoplasty from orthodontic surgery, either refort or mandibular splitting. But unfortunately, our patients are afraid from doing orthodontic, and they think that the solution will be with rhinoplasty alone. This will not make us unable to get the best results. Another problem, which is extreme subtle deviation, exceeded what is seen in cosmetic rhinoplasty. Bony and cartilaginous subtle are deviated from meridian groove, displaced into the nostril floor, turbinate hypertrophy, and palate. Even it's so difficult. Many patients begin easily with injury to the palate, with fistula, with the oral cavity. Turbinate hypertrophy, of course. Cartilaginous dorsum, secondary affected, traditional SMR may be inadequate. This patient shows nasal airway obstruction. There is a study which has been shown that in patients with cleft lip and cleft rhinoplasty, most of the nasal obstruction will be in the bony parts, in the Pomerian and the perpendicular plate of its mold. So, radical submucosal resection. We need to find the cartilaginous septum, vomer, perpendicular plate, and release nasal floor, excision bone, and cartilage septum, and to bring good support. Most authors at now today will not operate cleft rhinoplasty without costal cartilage graft. Unfortunately, contact cartilage will not be enough. Remove bone posteriorly even to the sphenoid in order to get good function. This CT showed that most of the airway problem will involve the Pomerian perpendicular plate stool. Most of them, and with severe deformation, even make us unable to use part of the cartilage as graft. So, as I said, most of the authors today go with costal cartilage graft in all cases with cleft rhinoplasty. Actually, we have to do a good assessment because to be honest, most of us as a surgeon will get attention to the tip, even the patient firstly, without get attention to the other part of the nose. If you just improve the part of the nose without addressing most of the problem, you will not get the best results. If we look to this patient, he has a septal lesion to the right side. You cannot be able to do reduction in just lateral osteotomy alone. So we do what we call monoblock nasal osteotomy. It is similar to what when we use in cosmetic rhinoplasty in preservative rhinoplasty, we do radical submucosal resection first, remove the sibling of the bone septum. We do low-to-lateral osteotomy, we do percutaneous radix excision, and by pressure we reduce the bone and the dorsal aesthetic line, preserve the bony bridge opposite to the head side, and we can get the best results in a few complications. Also, as we said, we have to think every part of the cleft rhinoplasty. We have to improve, to bring a good support, spreader grafts. Even sometimes we just keep, to me I use visor, so even if I remove most of the septum, I make a hole in the bone, then I connect with permanent, the costal cartilage with a permanent suture as like ulcer foot. Another problem we may face it, hypoplasia of the nasal spine. So I have to bring a good support, as I said, instead. Many techniques will be used for rotation and tip projection, either septal extension graft, pyramidal supports. Another thing, the lower part of the cartilage should be repositioned to its normal position. It is hypoplastic with scar tissue. So in order to address it and to correct it perfectly, you have to think about the soft tissue too, not just the cartilage. Because if you return the cartilage alone, you will face some problems, scar tissue, because not move with you. So every case is a special identity. Sometimes we use, to me I will be not special for the use of pulmonary root. I second and work best, as I said, if cartilage not rigid as enough. Sometimes as you see the angles look very helpful. That's why I use septal extension graft from rib cartilage in a way that reduces the risk of rotting of the cartilage. We have some gene we use sometimes in special patients when we have just not realized the rim. We use inverted new incision accessible lateral for repositioning, address the nostril apex overhang, can create a soft tissue triangle, originally closed rhinoplasty combined with open rhinoplasty. Lower lateral cartilage repositioning. If we have, I think about medial transposition of the cartilage, nasal lining may limit medial movement, but we sometimes use what is called putter technique, which means transection of the lateral nasal lining, medial transposition of the lower lateral cartilage by closure of the mucosa. This can be used only when we don't have a lateral alar deposition. If we have such case, if you look at this case at the same time, you look at the symmetry is simple, but we open it, you will notice there is a major difference as you suspect. As we said, you have to put in your mind many techniques to deal with each patient alone. So in this patient, putter technique will not be enough. We'll prefer to use different technique, which is mean lateral transposition of the cartilage, lengthen the columella, medialize the alar base, stability of the may be used, radical rotation, stabilize nasal split, and in addition to open rhinoplasty. In some cases, this patient with rhinoplasty, I do for cleft rhinoplasty, lip scar revision. This is the picture I will set after about after about 9 months. Unfortunately, the patient expectation in such a case is so high. They think if they see primary rhinoplasty or cosmetic rhinoplasty, they think they will get the same results. Many patients are refused to operate them because they think they see the picture, why I didn't look like this. They didn't know the problem they have it. You are dealing with something completely different. You have dealing with heart tissue, even if you drink whatever you drink. You will have with not just heart tissue, thick skin, thick nerves, not just cardiac. So our expectation always we face in cleft rhinoplasty. It's another patient with severe deviation. I do cost cartilage graft for him. I try to do one of them in this case, but I can't. So I will open physiotherapy, lateral physiotherapy. Actually, when I open it, the nose stopped because the nose dropped because I did total SMR. So as I said,